Welcome to today's webinar. On behalf of Amy Armstrong, Carolyn, Hawley, I'm Ben Darter, and we're continuing our series of webinars and state of science presentations on the theme of veterans with amputation as it relates to their experiences and particularly employment after the injury. Sort of alluded to this already in the fact that we're part of a larger group of individuals studying this, and that we're really looking at some different factors that are facilitators or barriers to those veterans or service members with amputation trying to re-involve themselves with the community, re-involve themselves with employment. Part of what we are looking at in a broad sense is trying to develop a multi-component model, which will look at helping them become competitive in the employment workplace. Just as a reference, you can see a couple bullets there indicating that we've done some of these prior webcasts and presentations, and those are archived on the Virginia Commonwealth University RRTC.org, but VCU-RRTC.org website. You can listen to all those at your leisure. And then there's also some articles that we've published lately on the topic as well. So for today's presentations, though, the real objectives are that we're going to talk about some results we have from a questionnaire that we've put out to a sample of veterans with amputation. I'll provide a little bit of information about the descriptives of those individuals, and then we'll also talk about some of the characteristics and factors that are related to their employment status, as well as we'll focus a little bit more on resilience and the role that that might have in employment. So for those of you who may not be familiar with service members with amputation, I'm going to provide a little bit of background. In general, across the U.S., there's about 2 million individuals with amputation. Each year, there's about 50,000 new lower limb amputation. The overwhelming majority of amputations occur due to problems with circulation, diabetes, something that leads to infection and ultimately limb loss. Of that group, there is a much smaller segment which might have it for other reasons. About 20% have it due to trauma, cancer, or congenital deformations. But really the focus of our talk is going to be on those who have experienced an amputation due to combat service. And so if you look at the people who have served recently in Iraq and Afghanistan in the last 15 years or so, what you see is that there's been about 1,700 amputations. That excludes people who've just lost a finger or a toe or a part of a hand or part of a foot. So this is significant limb loss in terms of being above the ankle, above the knee, above the wrist, above the elbow. What you see in general is that when we talk about how those folks have done, literature out there has looked at this question before, has shown that in general, people with amputation, this is including civilians, have a fairly broad range in terms of return to work. And so you see as many as 70% and as few as less than half potentially returning to work. If you take a look at the literature related to the military individuals, you see that far fewer actually return to work, and you see employment rates, return to duty rates of less than or about 13%. And as we'll highlight later on, and with our own data, is that there's some significant changes that happen in order for those individuals to return to work. And also we'll kind of highlight the fact that there are a lot of factors that may be very unique to this military group in terms of what influences their return to work. So as I alluded to, we've kind of talked about this in some other presentations, and so I just want to summarize some of the prior work that we've done, and this involves just a general review of the literature as well as some qualitative work. And so what we see across the literature and across our earlier work is that individuals after amputation really do tend to change their jobs, and there's some characteristics in terms of maybe the physical demands that really make a difference as to what they do or do not do if they return to work. What we do see without a question is that work does matter, and that there's some linkages between resiliency and the level of pain that they experience and whether they return to work. In general, functional outcomes after amputation are mixed. It does have a role with the likelihood of returning to work, but in general, function is mixed. Some studies show that service members with amputation go on to be very functional and maybe even equivalent to people without an amputation. Other studies say or show that they perceive themselves as having far greater disability and far lower quality of life. So it's hard to say, it might be just difficult to make statements about the group as a whole. Our earlier qualitative work also shows that there is a strong component of giving back, that they really want to be helpful both to other individuals with injuries, but also to their community at large. And maybe that's not totally surprising considering that they felt compelled to serve their country. And then also the fact that they are experiencing relationships, and those relationships can have a profound impact on their overall reintegration with the community and potentially within the workforce. So as to the questionnaire that we're going to talk about, there were some research questions that we developed, again, alluding to what I said before, which is that facilitators and barriers to employment was an important part. We were also looking at some of what the services are that they maybe receive and what their satisfaction level with those services are. As I mentioned, we're going to focus a little bit on resilience. And though we don't really talk about this in terms of the results of the questionnaire, this ultimately is building toward the idea that we want to develop a model which is going to have these kind of important factors identified, which we can then use to help facilitate return to work amongst veterans with amputation. So just a little bit of very brief background on the questionnaire. It was designed to really assess the demographic characteristics of the individual, their employment status, as well as delve a little bit into what their life experiences were like. For some of you who might be interested, we took some questions and modified them a little bit, but we took them from the questionnaire for persons with transfemoral amputation, the QTFA survey, as well as a non-amputee specific, but the CD-RISC, which is a resiliency scale, and Dr. Armstrong will talk a little bit more specific about that in her part of the presentation. As far as our participants, we were focused on the individuals who served and had the amputation during OEF, OIF combat. So in general, this is a younger group, but because we were also focused on employment, we also wanted to make sure that we captured that group that would be in the employment range. So in the 18 to maybe about 55-year-old range, we felt was a good range to use. For identifying this sample, we relied upon the VA corporate data warehouse where we could input certain terms and identify those individuals. So in this case, we used the medical diagnosis, the ICD-9 codes for major amputation levels. We also used the flag they used to identify those who have served in OIF, OEF, as well as our age range. The individuals we identified, we contacted through a mail flyer, and we did that on 2 separate occasions. And in that informational flyer, we indicated that they could take it either as an electronic questionnaire online through a web porthole, or there was also in one mailing a hard copy of the pen and paper version of that same questionnaire. So basically just trying to develop a way that would be most convenient for those individuals. So as far as the results of what we accomplished, well, we yielded 870 addresses from the corporate data warehouse. That's obviously far less than the total number of individuals who have experienced amputation, and there's a plethora of reasons as why that might be. Maybe different diagnosis coding, whether they've actually sought care through the VA since they've left the DoD, are among the different factors that may have been at issue as far as not yielding the entire group of service members with amputation. Of that group, 154 addresses turned up as being no longer valid. And so of the remaining, which is about 714, 165 actually completed the survey either via online or through the pen and paper and returned it. So a 23 response rate overall was found, at least with our mailing. So I know these slides may be difficult to say, so I'm going to try to summarize a lot of what those tables are telling you. So in general, when we think about the sample that responded, we see that overall, as it probably makes sense, these were by and large very young. 3/4 of the individuals were under 40 years of age. Not surprisingly, they were predominantly male, but in other characteristics, they were predominantly white Caucasian. Most had some type of college degree, and in terms of family social characteristics, the majority of them were married and had children. In terms of their overall medical status, of course, they had an amputation. But if you look at where the amputation occurred, the majority of it occurred at the lower extremity level. In general, compared to civilian rates, the rate of individuals with upper extremity was much higher in our sample, although that's not totally surprising, considering that in many cases the trauma that caused the amputation certainly was whole body, things like IEDs, which would have a much higher risk level for impacting the upper extremity. And so the same would go for in terms of people who had multiple limb amputations. The rates of that among service members is certainly much higher than in the civilian world. We also found amongst our sample that the likelihood of having comorbidities such as a traumatic brain injury, some type of diagnosed anxiety condition or PTSD was highly common. Again, that may not be totally surprising given the media coverage surrounding these types of complications for service members. In terms of their service record, we see that the majority were from the Army and Marine Corps. Their service length varied quite a bit. You had some that were not in the service for very long at all, and over a quarter had been in for 10 years or more. So quite a varied service length. In terms of where they served, the majority of them were enlisted, and most of them reported to be in occupations that were highly physically demanding. And that's a part we'll come back to again in terms of when they return to service, when they return to work, what type of demands are placed on what can they tolerate. In terms of the actual kind of functional outcomes, I alluded to sort of mixed data out there in the past. Within our sample, what we see is the majority perceive them as actually fairly average. If you lump in with the people who see themselves as high, then yeah, the majority see themselves as average or better than what they would expect for themselves. Interestingly, that comes while a quarter of them view themselves as having prosthetic problems, and that may be related to the fit, or comfort of the limb, but also it has to do with whether they have skin problems and other things like that. So people are perceiving problems, but still perceive themselves as being very functional. And of course, the fact that if you look at the table, the bottom question refers to how much assistance they need, and an overwhelming majority, almost 75%, don't even use a single cane or crutch or anything to get around. So people are fairly mobile. Literature has talked about the importance of pain. I mentioned that before. In our sample, you see that over 40% reported considerable pain. So that's obviously a significant problem. In the table there, you can see the first column has a P, that's for the prevalence. So again, 40% saw considerable pain. The second column, which has a W, stands for how much of an impact that has on work, their ability to work. And you can see that, again, that pain does have a significant impact on their ability to work. And then the third column there, which is the quality of life. So how does it impact their quality of life? Again, you see that the level of pain as perceived by our respondents was that it was quite significant. And again, that's not just in terms of pain in the residual limb, but also in regards to pain in other places, which are very common amongst persons with amputation. The back, the shoulder, other legs, all of those are fairly common. And you can see that certainly pain does have the potential to impact their work and quality of. That being said, one of the interesting findings that I see in this data here is that while the number who see it as being, their pain as being moderate, the number of people who actually see that as impacting their work or quality of life seems to be quite lower. So while they may perceive pain and have a lot of pain, the actual impact on their work or their quality of life may be lower in some cases. In addition, again, I mentioned skin difficulties, sores, chafing, blisters. All those are very common in individuals with amputation. And in this case, you see that, again, over half are reporting some type of skin complication. Again, interestingly, what you see, though, is that while they, again, report the occurrence of these problems, that the actual impact on work and quality of life is much lower. So you can see that, for example, the prevalence of people with moderate problems is somewhere around a quarter, but less than 20% are seen as a problem in terms of their work. So again, there's some people who are having it, but they're able to overcome that, and maybe that speaks to what will be talked about later in terms of resiliency. In terms of the services that these individuals are using, you see almost exclusively everyone is using some type of health care. You see mental health counseling as well is being highly utilized, but in general you see pretty varied use of different services, and there'll be some other services on the next slide to kind of continue this. But in general what you see is that as far as satisfaction goes, that it's pretty varied, and in some cases they're quite pleased, quite satisfied, and in other cases they're maybe quite not as much. But also keep in mind too that in many cases many people are not using the services at all. So that's, in terms of a future question, one of the things to look at or look into is why are people choosing not to, or is it because they're not aware, or are they actually choosing not to use these services? Again, this is just continuing, and you see that on this particular slide, people are using a lot of educational related services, and in many respects, that tends to be the one that people are most satisfied with. So education is a theme that's important and seems to be well received. As far as the people actually providing those services, organizations like the Department of Defense, the VA, charities, what you find is that our respondents found that organizations like charities and the Department of Defense, as well as the VA Voc Rehab, tended to be most well received, that they were most satisfied with that. One of the things I found very interesting was that VA services, the respondents also were pretty satisfied with them. However, unlike some of the other categories, which you also see is a pretty large number who are dissatisfied. So this seems to be one of the few service providers where you're either very happy or you're not happy at all. So I guess kind of like online comment sections where people are either going to be very glowingly positive or not, whereas the other ones, just people tended to be fairly pleased or hadn't used the service at all. So at this point, I'm going to turn it over to Dr. Hawley to continue with talking about how employment rates and some other issues relate to this sample as well.
Okay, and thank you. And as Ben mentioned, our point was, or at least one of our point was, to try and explore the unemployment rates for our OEF, OIF veterans with an amputation. And the reason we wanted to do this is historically, when we've been tracking unemployment rates for veterans in general, we found that they've been much higher than for civilians. And just as a reminder, unemployment, what they're looking at is individuals who are actively in the workforce, and yet they can't find a job. They're not considering people who've already just disbanded from the job search. However, today, most recent unemployment rates show that we're in a boom. From April 2018, our unemployment rate in general for civilians is about 3.5%, so almost non-existent. And it's really close for veterans at 3.7%. However, when we carve out our OEF, OIF veterans, we find that it's higher. It's 4.5%. And of this group, we don't know how many individuals have an amputation. We suspect that those rates would be much greater. And there's a number of reasons for that. We find in the research age, education level, prior work history, litigation, pain. All of these variables can have an impact on return to work rates. So we see highly variable return to work rates from study to study. Also, what we do know, and what Ben also alluded to, is that for individuals who return to work following an amputation, it's very rarely going to be their same job. It's going to be a new job that's less physically demanding and also with some type of job modification or accommodation. However, since we're looking at military members, what about return to military duty? Again, the odds of returning to military duty are very low. Studies range from 11 to about 13%, of which almost all of these who have returned to work, they're doing so in a modified job capacity. Over half, about 56% of our military members with an amputation are determined fully disabled. But of special note is when we look at our military branches, we do see variability with return to duty. For instance, our special forces have the highest return to duty rate of all other branches, despite there not being any difference with the severity of the injury. And we again suspect that when we're looking at special forces, these are individuals who are highly skilled, highly trained. So perhaps in that branch, they make a greater effort to return these individuals back to duty. What about return to civilian type jobs? And here we wanted to highlight two major outcome studies. Okay. One focusing on civilians, and this is the Lower Extremity Assessment Project, or LEAP. The other focusing specifically on the Military Extremity Trauma Amputation Limb Salvage Study, or the METALS. Now, both of these were comparing outcomes of limb salvage versus amputation following a lower extremity trauma. And we're not going to go into the outcomes regarding that for this webinar. However, what we do want to highlight are the return to work rates. And what you're going to find with the LEAP study of our civilians is 51% were working. Whereas we see a reduced rate with our military members. Here we only have 43.7% who are working. However, just note the differences with individuals who are in school. When we look at our medal study of our military, what we find is 22% of individuals were currently in school, whereas we only find 3% in school with our civilians. And again, this is probably related to when we have our military members, they tend to be younger, and we also have greater education benefits for our service members. So that's probably accounting for those differences. I also want to point out is for the LEAP study, when we looked at return to work, is what they found really surprised them in regards to what was going to be the most significant variable in regards to who returned to work. It wasn't pain, it wasn't severity. What it turned out to be was self-efficacy. And self-efficacy is the belief that you can accomplish some task. So individuals early on after their injury had higher self-efficacy. These were the individuals who returned to work. Not surprisingly, individuals with low self-efficacy withdrew. And these were the individuals who did not. Another finding of the LEAP project was in regards to relationships, that people who had higher levels of support were also the individuals who returned to work. Also have here another study done by Reiber, and they looked at 317 OEF, OIF service members following a lower limb amputation 1 year post-injury. And what they found was 53% of individuals were employed, 22% were in school, and 21% were retired. Now this takes us to our data. And when we look at our data, what we find is we have much less individuals who are employed, only about 38%. We also have higher numbers of individuals who are unemployed than the previous studies. I just want to note here is when we look at our unemployed category, we also have within that category, less than half of those individuals are currently in school. However, those numbers still, as compared to the medals, as compared to Reiber's study, we have less individuals in school. We also have greater numbers of individuals who are retired. So, looking at our employment statuses, so individuals who are employed, unemployed, and retired by demographic characteristics. First off, age. Research has shown that age matters, that the younger you are, the more likely you are to be working. For older individuals, the less likely you are to be working. And how the physical health of the amputation plays into that, we suspect that there's some deterioration there as well. Yet in our study, age is not significant. And perhaps it's because we do have a bulk of individuals who tend to be younger. We don't know. Now, what about the type of amputation? Here too, in research, it's been mixed. Some studies have said that the type of amputation matters, others not so in regards to return to work. And for us, it didn't matter. Also, time from injury. In all of our categories, it's very similar. It ranges from 6.5 years to 6.9 years, so not significant. And this leads us to education. Previous research says education matters, that the more education you have, the more marketable you are, the more skills you have. With us, this was significant. So individuals who were in college, they were much more, or I should say had a college degree, they were much more likely to be employed. Whereas, if you just had your high school diploma or some technical training, you were much more likely to be retired and then out of the workforce. And when we did our multivariate analyses of all of the variables, there were three things that were most significant in regards to employment. One, as we mentioned, was education. The other, pain. Individuals who had more pain or reported more pain were less likely to be employed. And finally, resilience. Individuals who had higher levels of resilience were more likely to be employed. And this also harkens back to that LEAP study in regards to self-efficacy. And Dr. Armstrong will talk more about this. And with resilience, we just don't know the direction for our study. Are individuals who are more resilient more likely to be employed, or does employment also have a factor in building resilience? So future studies. So what about those individuals who are currently employed? What does their situation look like? So 92% did not return to the same job. And this isn't surprising considering that these were service members, and we know the very low return to duty rate. And 80% reported that they couldn't because of their disability. What's interesting, when we looked at employment sectors where individuals are working, we see across all sectors: healthcare, education, business, computers, agriculture, construction. However, the majority, 33% of our sample who was working, they're working in the government sector. So the government sector is doing really well in regards to hiring our veterans with disabilities. And that's probably related to some of their hiring practices that does give preferences to these groups. As far as their current job, what we found, again, vast majority of individuals are working, 80-some%. We also find about 74% say that their current job is neutral or not at all physically demanding. About less than half, around 40-some% of individuals consider their current work productivity to be less than what it was prior to their amputation. And the good news is when we look at individuals and their current job, we have about 70% of people saying they really like their job. They also feel that they're using their skills and their strengths on this job, as well as they don't plan on leaving this job in the next several years. So they're sticking around in these positions. Although to note, when we did ask individuals in regards to, would you consider changing careers, we had 40-some% saying yes, they would. Although we can't say if this is a response to this particular population or if it would be all of us having a similar response.
Hi, I'm Amy Armstrong, and it's good to be with you today. I want you to think about the last month. Think about a challenge or a struggle that you've experienced. How'd you move through it? How did you respond to it? What skills did you use? How did your thoughts or your emotional consideration or aspects in response to this challenge present themselves? So we're talking about resilience here, and resilience is the ability to adapt well when you're experiencing struggles, challenges, or adversity. Trauma, tragedy, all of those events that challenge us, they become major roadblocks or bumps on our journey. It also means bouncing back from difficult experiences, and research has shown that resilience is something that's ordinary. It's not extraordinary. Most of us are resilient individuals. Oftentimes when we're talking about resilience and we're talking about how we respond to challenges and struggles and adversity, it's really creating a certain level of emotional distress. And so we really wanted to take a look at the resilience of veterans who experience amputation to see how they were responding or what factors were contributing to their resilience. So if you look at the literature that exists around aspects that promote resilience, you're going to find most studies are going to say the more education you have, the more resilient you are. And perhaps that's just the opportunity to learn coping skills, emotional intelligence skills, having a sense of community or a sense of purpose. We're not quite sure, but education does have an involvement in resilience. The older you are, the more resilient we have a tendency to be. I'm coming up close on 60 years old, and I can tell you I like to think of myself as having a little bit more wisdom in my life now that I've experienced so much of it. So we shall see. But typically, if we are older in our age, we're a little more resilient, and we're a little more adaptive on how we respond to those struggles or challenges. Social support, what's our connections, our relationships, specific training. Have we had training around resilience, around our emotional intelligence, stress management, stress reduction? Absence of early life trauma is another indicator that can promote resilience. Our genetics is a factor as well. If you take a look at some of the positive psychology research that's out there, especially, and I can't say her name, Sonia Leyer-Bermersky, her research and other studies have indicated that 50% of our well-being or 50% of our happiness is based on our genetics. So what we were born with has a huge impact on how we experience life. And do we look at the glass as being half full or half empty? And that has to do with our optimism and or our pessimism. So again, some of the characteristics that could impact resilience, and think about your experiences that you've just had in the past month. Do you see any of this? Seeking supports, being willing to ask for help, having relationships that make a difference in your life, that contribute to your well-being. What's your purpose in life? Do you have goals? Do you have a sense of meaning in your life? Do you feel as if you're contributing and making a difference? What's your belief in your ability to overcome adversity and to influence the events or the outcomes of events? And that gets back to what Dr. Hawley was talking about in terms of self-efficacy. And a belief that we can learn from and grow from our experiences. We don't just look at those experiences as happening to us, but we really embrace them as an opportunity to learn and to become wiser and to become more adept and to grow. Are we able to engage in self-enhancement and use these lessons lifelong on a daily basis? Do we experience positive emotion? And again, the research shows that if you have a positivity ratio, generally speaking, of about 3 to 1. So for every one negative statement or emotion I experience, am I experiencing about 3 positive? Then I will probably be flourishing or thriving versus languishing. So what are our positive emotions that we experience on a daily basis? And do we laugh? Do we use humor? Do we have lightheartedness experiences and opportunities in our life that we recognize? So in terms of some of the research that's been conducted out there, Rivik and Shate have identified 7 factors. The first one's emotion regulation, and that's the ability to stay calm under pressure. Are you able to get through a certain scenario or a situation without acting out or popping off, I guess is a good way to put it. And again, that ties into impulse control. That's the ability to shut out distractions and urges to restrain our reactions. That's the ability to rethink our behaviors and the way we see ourselves. And this has to do with impulse control. And, you know, if I experience a challenge or a struggle, do I go out and make decisions or do things that maybe I shouldn't? For instance, I might go out and buy those $155 Everlane shoes that I want because I had a hard day at work yesterday. And that might have something to do with my ability to control my impulses. I believe in retail therapy, though, so that might have been a poor example. Causal analysis, that's the ability to comprehensively and accurately identify the causes of a problem. Let's say I go out for a job interview and I don't get the job. So in my mind, I might think, well, they didn't like me. I didn't get that job because they didn't like me or I wasn't good enough. Or am I able to reframe that and say, well, you know what? They may have had someone else in mind already, and this was really a good opportunity for me to get some experience interviewing and to learn from that, and I'm going to be better next time. So that's causal analysis. Are you a victim? Does the world happen to you? Or do you have some level of influence and ability to impact your life? As Dr. Hawley mentioned, self-efficacy is a huge aspect of resilience, and that's just my mastery and my competence. Do I feel good about my strengths and my skills and my ability to use them? Realistic optimism, that's where I believe that I can change for the better, that I can control the direction of my life, that a situation may have happened, I can't control that situation, but what aspect of it can I influence? How can I make a difference? My level of empathy, and this is huge around emotional intelligence as well, and that's just my ability or your ability to read others' cues to their emotional and psychological states. And then finally, do I reach out? Do I test myself? Do I push myself to try new things, new opportunities, new challenges in relationships, and to learn? So these are some of the factors that have to do or comprise resilience. There's two lines of thinking in the literature around resilience and reintegration of veterans. One is that resilience is about overcoming our challenges. The second one is that there's evidence that resilient individuals are less likely to incur post-traumatic stress disorder and similar mental health conditions. There's actually an opportunity for post-traumatic growth, that I can become better as a result of this experience or learn from this experience. So the research questions we wanted to ask around resilience were, what is the resilience of OEF, OIF veterans with amputation? What is the relationship between employment and resilience? And what factors and individual characteristics predict resilience? We use the CD-RISC, the 10-item CD-RISC, as Dr. Darder mentioned, which does have a Cronbach alpha of 0.85, so pretty good psychometric properties. And if you look at the research that the developers of this instrument have done, the initial application to general population had a mean score of 31.8. Additional studies, you will see ranges of 29 to 33.5. Some of the additional variables that we collected in this study were the type of amputation people experienced, pain and level of pain, prosthetic use, and the perception of the impact of the amputation on quality of life around items such as transportation, community activities, and their ability to work. And again, if you'll note, this is their perception of the impact of the amputation on their quality of life. So we had a mean sample of 28.2, which is within the mean scores of earlier research or earlier populations that have experienced trauma. And you'll see those ranges typically from 20 to 31. So this sample is a little bit towards the higher end of the scale. If veterans were single, their resilience was 29.5, and this is counterintuitive to prior research. Typically, relationships do impact resilience, but this particular sample, you can see that average mean was 29.5. If you were married or partnered, just a little bit less, not enough to be significant, but that was a little interesting. However, if you were widowed, divorced, or separated, your mean score was about 25.8. And that makes sense because divorce or losing a partner is a significant traumatic event or experience. Interestingly, variables that weren't related to resilience in our particular sample were age, which in other studies have been found to be significant, race, amputation group, and education, which has also been found to be significant in other studies. If you look at our significant variables, employment, you can see, had an impact upon resilience. Pain, whether or not participants felt more pain, a great amount of pain versus a moderate amount of pain. Difficulties participating in social and community activities impacted resilience mean scores. And perception of overall situation as an amputee. And again, if it was average or good versus poor. Also, the prosthetic use was a factor as well. How long were individuals using their prosthesis? And we used 7 hours or less to 7 hours or more. These were all significant variables in our particular sample. So let's take a look at this. Employment. We had nominally higher resilience if employed, which was interesting for us. If you take a look at this, those disliking jobs had lower resilience, around 24.4 as their mean score, compared to 31.2 who liked their jobs. And again, if we're using our strengths, our skills, and our training, you can see that resilience was higher as well. Now, uses of strengths has to do with employee engagement. So if I'm able to use my strengths, I'm more likely to be engaged in my job and really like and value my job. Pain also, as we mentioned, in both the residual and non-residual limb was a variable predicting resilience. Difficulty participating in social and community activities. So those that were more active, more involved, had more opportunities to engage with other individuals, had higher resilience. And then again, the summary of our overall situation as an amputee. Those who perceived their life situation lower or in a worse condition had lower resilience. So what we're looking at here in this particular slide is veterans with amputation experience higher levels of resilience if they were experiencing less pain, they were using their prosthetic 7 hours or more, they were employed, they had opportunities for engagement and relationships, and they perceived that their overall quality of life was at a higher level. And look at this. If you perceived your quality of life as being poor, your mean score was 22.4. That's really quite low. If you perceived it as being good, it was 32.6, which it really mirrors general population scores of resilience. If veterans reported a slight impact across characteristics, the mean scores are actually within the range of the general population. So we had, if a veteran thought that their situation was more optimal or more favorable experience, they range from 30.4 to 32.6 mean score on the CD-RISC in this study in comparison to the general population, which is about 29 to 33.5. Characteristics associated with the experience of amputation really do appear to impact resilience, employment, and life, as do our perceptions or the perceptions of veterans of how it impacts their life. So if we look at ability to work affected by pain, you can see the differential in the mean score. If veterans thought that they had slight trouble in terms of their ability to work or to contribute on the job, they had higher levels of resilience. Again, pain, if they had a slight pain, they had a 31.9 mean score. And if they experienced additional pain other than the limb itself, the back shoulder and an additional limb, you can see that they had higher resilience mean scores. So when we think about when we're working with individuals with veterans who have experienced amputation, some of our considerations are going to be prosthetic use. And Dr. Darter is an expert in this area, so feel free to jump in if you want here. But it has to do about fit. It has to do about individuals' physical and psychological comfort. Does it contribute to my self-efficacy? Can I really enhance my sense of positive identity and inclusion through the use of a prosthetic device? And many times we're seeing OEF, OIF veterans have access to a higher quality of prosthetic device than perhaps the general population as well. And again, if veterans are using prostheses more often or longer throughout the day, they're more likely to remain employed as well, according to a study that was conducted by White. Being employed impacts resilience, community connections, and a sense of meaning. What's interesting about this population as well, or this particular sample, is that we had a large group of individuals that were retired. And you can see that they reported a slightly higher mean score in resilience than individuals who are unemployed, with those being employed, of course, a higher mean score. There's literature and research that's been conducted that really recognizes the intersection of career, social, and community well-being. It's well documented that if individuals have career well-being, they're more than twice as likely to be thriving in social and community well-being as well. So it's really important to look at individuals holistically to get a sense of their life, what they're doing both on the job and away from the job, what the quality of life looks like, relationships look like, and opportunities for integration, what those look like. Some of the limitations, this was a small sample, as we had stated earlier. It is based on self-report or the perceptions of veterans. And we have several recommendations for future studies. So if there's any researchers out there, any scholars out there, and you're interested, give us a call, let us know. Some of the suggestions we had were really looking at mixed method approaches. So one would be qualitative interviews, possibility short interviews of individuals and their family members in terms of quality of life and employment and factors that impact their quality of life and employment. Use of a diagnostic measures such as the quality of life scale that have really good psychometric properties and are specific survey responses, and you're able to really conduct some solid analysis of those results. If you recall, on our particular study, we compiled several single items that had to do with perception of quality of life around transportation, community involvement, employment, that sort of thing. Some other areas that we would be curious to explore would be exploration of return to work and promising practices to facilitate that return to work. Typically, veterans do not return to their previous occupation. So what's happening with these individuals, and what sorts of employment are they actually experiencing and engaging in? What about retirement? You know, it was really interesting, and we started talking about the impact of benefits. For this sample, there was a disproportionate number of veterans in terms of younger age. We had only 19 that were age 46 and higher, yet 42 individuals were retired. So there's a real disparity there, or disconnect there. And what is the impact of receiving such benefits on one's willingness or desire or ability to return to work? Again, exploration of pain management strategies. This could include mindfulness based stress reduction strategies, perhaps meditation, other pain management strategies as well. An exploration of those individuals who report higher resilience. What are their psychosocial characteristics? What replacement activities do they engage in? What do their support groups look like, or their community relationships or activities look like? And then the development and implementation of educational training and networking opportunities that are long-term, that are sustainable, that are designed to support veterans and enhance their psychological capital and their employment experience. These are some of the areas we'd like to see additional research conducted. So finally, when we're thinking about some of the topics that we were discussing today, we really can infer causality, and Dr. Hawley mentioned this a little bit earlier. Are resilient people more likely to be employed, or does employment result in higher levels of resilience? This is an area I think that could lend itself to further study and further learning when we're looking at veterans, but when we're looking at the general population as well. And we'd be curious to see what your thoughts are in this particular aspect as well. Anyone have any other concluding thoughts? I think the big one for us was that we're really excited in the potential in terms of the development of educational skills building interventions and training that can really make a difference in the lives of veterans and assist them in pursuing a quality of life that is enviable, that they are proud of, in which they are really contributing to their families and their communities. And so we're interested in that return to work model and the development of interventions and training that really look at resilience, stress reduction, and job-seeking skills. Anyone else? No?
I would just add that, again, there's so many parties out there who are interested in helping support these veterans, and there's quite a lot of very successful organizations helping people in terms of returning to community through fun activities, like charities providing rides and trips to different places, and that helps in many ways. And I think what that really gets to is a lot of this, what you presented on, which is resilience. And so while educational support services and healthcare support services are out there and in general fairly successful in accomplishing what they need, I really think that some of this around self-efficacy and resiliency is really a piece of the puzzle that is underexplored, and something that I think we look forward to delving into a little bit more and see if that's really a mechanism for helping to support these individuals and make them more successful in re-engaging both in employment and in the community.
Yeah, and I think we were really excited to see too that if you look at the mean scores, many of the veterans in this particular sample, their mean scores were right up there with the general population. And so I think that lends itself to earlier research that's been conducted that most people are resilient.
Yeah. And I'll just conclude in saying is that's our next step, is we're going to be looking at resilience in our model to better help veterans with amputations get jobs and keep them.
Yep, sounds good. And we wish you well in your good work, and perhaps we'll meet one day and get to work together. Have a good life.